the time over to you.
Thank you very much, Dr. Kapu, and thank you everyone for tuning in at this time of the year. It is a great pleasure for me to be here. And I'm going to be talking about the patient, provider, and health system level determinants of hypertension outcomes in sub-Saharan Africa. But in summary, these are some of the things that I'm going to be talking about. I know I just got an introduction, but I'll talk more about myself a little bit. Uh, and then I will review the background on hypertension burden in sub-Saharan Africa. I'll give a brief intro on my prior research on hypertension care in Ghana. And then I will discuss the patient level determinants of hypertension outcomes, explore the clinician level determinants, then health system determinants, and then talk about some recommendation and policy implications. A bit about me, as Dr. Kapu just said, my name is Samuel Byiringiro, and I am assistant professor right now at Vanderbilt University School of Nursing. But I'm from Rwanda, which is where I grew up, and that's where I did my bachelor's of nursing at the University of Rwanda, during the time of which I got some interest and I engaged with different organizations, including Team Heart, which was really my initial interest in cardiovascular disease. Team Heart is a group of critical care nurses, doctors, and other specialists who had been traveling to Rwanda for over 15 years to provide screening for rheumatic heart disease and open heart surgery for patients who are identified. So I volunteered with them. And while working with them, it opened my eyes on the big burden of heart diseases. During that time, it inspired me to write about cardiac surgery and the lack of access of cardiac surgery in low and middle income countries, but also to collaborate on a book chapter which discussed the rheumatic heart disease in Rwanda and the capacity building efforts. And that was my work. And then later I was to come to the United States. And when I came to the United States, I went for my PhD at Johns Hopkins University, where I worked on my research on hypertension. My initial interest in cardiovascular diseases got me interested in looking, and then I realized that hypertension is one of the biggest precursor of cardiovascular diseases in general. And then I pursued my postdoc at Johns Hopkins as well under the funding of American Heart Association, where I explored uh, how to increase diversity and representation in clinical research and clinical trials. And that led me to Vanderbilt University, where I am currently working on looking to work on global health research for addressing cardiovascular disease prevention and management. And I'm also looking at research on symptom management in serious cardiac conditions. But let's talk about the burden of hypertension in sub-Saharan Africa. We know that approximately 1.4 billion adults worldwide have hypertension, and that two-thirds of them live in low and middle-income countries, mostly the countries in sub-Saharan Africa. Zooming in on sub-Saharan Africa, this study by Mears and colleagues show the prevalence of hypertension across different countries in the world. And you can see that sub-Saharan Africa has predominantly the prevalence of hypertension, which is 34% and higher, as represented by red color there. But even though we are talking about this in both men and women having high prevalence of hypertension, the prevalence is not similar within all regions of sub-Saharan Africa. For instance, this study by Chen and colleagues demonstrated that even in sub-Saharan Africa, some regions have higher prevalence of hypertension than others, where you see that, for instance, East Africa has the least prevalence of hypertension at around 27%, but other regions such as West Africa and Southern Africa have predominantly high prevalences of hypertension. And this really what it points to is the fact that it looks like some of the driving forces or factors of hypertension might be different by culture, which could mean that the interventions may need to be different as well. And when we talk about the burden of hypertension, it's good to see it as a process because there are people who have hypertension on this graph, But among those who have hypertension, usually there are people who are not diagnosed. And if you're not diagnosed, of course, you cannot be treated. But there are people, many people who are not diagnosed. And then there are other people who are diagnosed, but many times those who are diagnosed are not necessarily started on treatment because of different reasons, some of which we are going to explore. But even those who are treated, not all of them achieve blood pressure control, which, according to the latest guidelines, we would want to keep people to have less than 130 over 80 millimeter of mercury. And how does this hypertension treatment cascade look like in sub-Saharan Africa? Among all women with hypertension in sub-Saharan Africa, according to this study by Zhu and colleagues, which was published in The Lancet in 2021, and it involved different countries and different regions of the world, including sub-Saharan Africa. This study shows that approximately 52%, which is more than 50% of people who have hypertension, I mean, women who have hypertension in sub-Saharan Africa, they are not diagnosed. And which means that we have already lost them and we cannot introduce them to treatment. But also there's another 19% who are not diagnosed, who are diagnosed, but they are not treated. Another 16% who are treated, but they are not controlled, leaving only 13% of the people with hypertension in control. And this picture is even grimmer among men, where 66% of men are not diagnosed and only 9% have their blood pressure under control. And how does this treatment cascade look like across different countries in sub-Saharan Africa? This study by Shakir and colleagues, which was published in the Circulation, shows that as you can see, there is a high prevalence of hypertension, which is diagnosed and undiagnosed. And this study is across 17 countries in sub-Saharan Africa. And among those who are diagnosed and undiagnosed, how many are diagnosed? The prevalence of people who are diagnosed is even very small, where you can see, for instance, some countries having very small. Look at Rwanda, for instance, only 2.8% of the patients with hypertension are diagnosed. And among those who are diagnosed, as I said earlier, not all of them are on treatment. When you look at people on treatment, you find that the numbers are even smaller. Now, there are multiple factors that impact hypertension treatment and control. And these factors start from an individual patient level up to the macro level, including national and international levels. On looking at the individual level, of course, and we are going to look more into this, we can think about the biological factors, which could include age, sex, comorbidities, and social economic factors, but also we can also call these the social determinants of health at the individual level. But there are other factors at the provider level and other factors at the health system level, some of which we are going to be exploring that impact the patient's achievement blood pressure control. And the picture that I want to draw here is just to let you aware that the achievement of blood pressure control is not something simple, because many pieces have to come together and be in the right place for a patient to achieve blood pressure control, which is what makes this process really arduous and a little complicated, but doable. And how does this link to the social determinants, to the Sustainable Development Goals? We know that cardiovascular diseases are the leading cause of death, which in sub-Saharan Africa lead to premature mortality. For example, out of 18 million premature deaths under the age of 70, due to non-communicable diseases that happened in 2021, 38% were caused by cardiovascular diseases. And we know that cardiovascular diseases are one of the major group of non-communicable diseases, so are the leading cause of death among non-communicable diseases. So addressing addressing hypertension being the most common risk factor for cardiovascular diseases, would help us to address the target 3.4 of the SDG 3, good health and well-being, which aims to reduce mortality from non-communicable diseases and promote mental health as well. However, I have to mention that even though this is looked at as an outcome, there is an interconnection with other SDGs, including the first one about poverty, where, of course, there is linkage between other sustainable development goals and these specific goals. So there is interconnection between them. And what I'm going to talk about next is some of the prior research that I worked on in Sub-Saharan Africa. And mostly I will talk about the mixed method study that I engaged in Ghana. And I want to introduce it here because I will be talking about it as the presentation progresses. In this study, I conducted in Ghana in a city called Kumasi, which is the second biggest city in Ghana. And this study included 15 health facilities and 65 clinicians and 225 patients. And it was funded by different mechanisms, including the Johns Hopkins Discovery and Innovation Fund, Conway Scholarship, and Johns Hopkins Center for Global Health. And you can, of course, read more about these studies in the publications here, but I will be giving a bit of a picture on what I did. In terms of the method, this was a sequential explanatory mixed method design in which in the first phase, which was quantitative, we administered quantitative tools, including the service availability and readiness assessment tool, which was developed by the World Health Organization to assess the readiness of a health system to manage health condition. This tool was adapted to the measurement of hypertension service availability and readiness. And that's the tool that we administered to the 15 health facilities that participated in this study. Among healthcare providers, we wanted to assess their knowledge about hypertension treatment guidelines and their adherence or attitude towards those guidelines. And among patients, we measured their blood pressure, measured their adherence to treatment, and assessed the other characteristics of those patients that could be associated with outcomes. And after doing the quantitative measurement, we did some preliminary analysis. Then we used those findings to design the focus group discussion guide. And during the phase 2, which was the focus group discussion with clinicians, we did our first 15 minutes presentation of preliminary findings from quantitative surveys to the clinicians and clinical leaders. Then we engaged them within the discussion, seeking clarification on some of the gaps that were realizing in the quantitative survey or things which were not clear, some of which I will mention in this presentation. And in terms of participation, as I mentioned, 15 health facilities participated, and they were diverse in terms of the kind of health facility that participated. For instance, in terms of ownership, 5 of the 15 health facilities were private. 3 were Christian Health Association of Ghana, which is a kind of like a quasi-government and private, and 7 were government. And some of them have outpatient, just manage hypertension in outpatient department, which is a department that sees all patients who come to the health facilities. And other health facilities had hypertension clinics, or the clinics that are specialized for managing patients with either only hypertension or non-communicable diseases, such as hypertension and diabetes, and sometimes other non-communicable diseases. And in terms of clinicians, we engaged 67 healthcare providers, even though only 65 data for 65 were analyzable. They were mostly middle-aged, mostly female, and mostly nurses. And we engaged 224 patients as well, and most of them were female as well. Mostly were employed. 58% were employed, and their education also varied across the participants. Now, this leads me to talking about some of the patient-level determinants of hypertension care and outcomes. When we think about the patient-level determinants of hypertension care and outcomes, we can think about I usually call it biosocial, the biological factors and the social factors or social determinants of health. In terms of biological factors, of course, we are aware of multiple factors that are associated with patient hypertension outcomes, including sex, comorbidities, age, the lifestyle that people lead, the adherence to treatment or non-adherence thereof, and family history of those patients. All these things play around in determining patients' achievement of hypertension outcomes. But we can't ignore the power of social determinants of health as well. The education of participants of people, the access to quality healthcare, the place where they live, where they are in rural or urban areas, social and community context, and economic stability. All those things also play a role in patients' achievement of hypertension outcomes. However, some of these factors play a role in parent that is a little contradictory to what we used for, to what we would expect, and I will discuss some of these. In this study, here I want to highlight two studies, one conducted in three countries, Nigeria, Tanzania, and South Africa, and another conducted in Rwanda. In terms of biological factors, the study conducted in Nigeria, Tanzania, and South Africa, of course, noted among the biological factors that we are used to. People with higher BMI were likely to have higher prevalence of hypertension. And people in Rwanda as well, we saw that people with diabetes were almost 7 times more likely to have hypertension. And alcohol consumption was also associated with higher prevalence of hypertension in Rwanda. And in other data that I didn't even mention here, age, elevated age, I mean, higher advanced age was associated with higher prevalence of hypertension, which is something we expect as well. In terms of social determinants of health, however, we saw that in this study conducted in Nigeria, Tanzania, and South Africa, conducted by Guatude and colleagues, we saw that compared to rural residents, the prevalence of hypertension was 2 times higher in peri-urban residents, and it was 4 times higher in school teachers in Tanzania, and 6 times higher among nurses in Nigeria. And this makes one wonder, what is the driver of higher prevalence? Is it that because nurses are more likely to be diagnosed than rural residents, or school teacher likely to be diagnosed by rural residents? That's something worth exploring as well. But also this was seen in Rwanda, where we saw that in Rwanda, urban residents were 1.3 times more likely than rural residents to have hypertension. And then this makes us wonder, do people in urban area have some specific exposures to hypertension factors than rural residents? And continue to explore these, the determinants of hypertension diagnosis and care engagement. This study conducted this cross-sectional household survey of 784 adults in 2 districts of Tanzania, explored this pattern. And we found that, of course, men were less likely to have previous diagnosis, as we also noted initially. And people, as they age, they were more likely to have a previous diagnosis and to be engaged with care, which again, we could expect this, since as people get advanced in age, they are more likely to interact with the health system and be diagnosed. So they are likely to know to have a previous diagnosis. Now, looking at it from the social determinants of health side of things, we see that people with primary versus no education had 91% higher likelihood of having a previous diagnosis. And those people were also 2.5 times more likely to be retained in care. So higher education, better previous diagnosis, and better likelihood of being retained in care, which probably could help us understand some of the data we saw in a previous slide. However, something else here we see is that the health fee exemption, which is something that happens in some countries. It happens in Rwanda. And in this study in Tanzania, they say that people who have very low income qualify for having health fee exemption, where they receive care free of charge. And in this study, they found that those people were almost 6 times more likely to have a previous diagnosis, and they were almost 5 times more likely to be engaged with care, and almost 3 times more likely to be retained in care. And this provides a picture of probably the the potential lack of access to care, which is caused by the cost of care. Since this is painting a picture that people who have fee exemption are more likely to have better hypertension care and care outcomes. In terms of the determinants of blood pressure levels among the patients, the patient level factors, I wanted to draw you to the findings from the study that I conducted as part of my dissertation in Ghana. I also introduced it earlier. And in this study, we saw that people who are educated, who have secondary education compared to people with primary or lower level of education, they had 8 millimeter of mercury lower in systolic blood pressure, which again, speaking to people with high education, high education compared to lower education have better outcomes. And in terms of, again, patient level factors on diastolic blood pressure, we saw that adherence to treatment, another factor we mentioned earlier, higher scores of adherence to treatment are associated with lower diastolic blood pressure. And this is, of course, expected. And we see specifically the association within the diet subscore, people who adhere to the diet as taught by the clinicians. In terms of determinants of uncontrolled blood pressure, I wanted to draw you to two studies as again conducted in Ghana, a multi-center study in Ghana, which was hospital-based and involved 2,600 and more patients with or without diabetes, and another study in Ghana, which used demographic and health survey of 12,800 households. In the study in Ghana, in the multi-center hospital study in Ghana, we found that yes, male were less likely to have controlled blood pressure, and people with diabetes mellitus comorbidity were 2 times more likely to have controlled blood pressure. And people with higher filtration rate, glomerular filtration rate, or better renal function, had lower likelihood of having uncontrolled blood pressure. These are biological factors, of course. But on the demographic and health survey study, it looked at the association between blood pressure and the wealth status. Now, in developing countries, we are used to knowing that people with higher wealth usually have better blood pressure outcomes and better hypertension outcomes. But in sub-Saharan Africa, we see a little different of a picture, where in this study, they demonstrated that people who are richer, and this was measured in terms of the properties that they own or the household assets that they own, and then it may help them to classify people into quantiles of wealth from poorest to richest. And we see that people who are richest had more likelihood of having poor blood pressure outcomes in this study, and it even adjusted for BMI. But then we also wanted to know how about people who are more rich but are educated. Even when we divide this by education status, so among, for instance, looking at people with no education, we still see this trend. Even among people with primary education, we see the same trend. In secondary education, we see the same trend. Even though in people with higher education, we see the trend, but the associations are not significant, which again paints a picture of what's happening. People who have more income have poor blood pressure, are more likely to have high prevalence of hypertension. And another picture that I wanted to paint is in terms of adherence to hypertension treatment. The patient non-adherence to hypertension medication is also among the main factors of uncontrolled hypertension, because, of course, a medication can only work if a patient has taken it. And in this study, which was conducted by Marquardt and colleagues, it found that, yes, there was high level of low adherence to treatment, which in middle-income countries of Sub-Saharan Africa ranged between 33% and 15%. And in low-income countries ranged between 55% in Democratic Republic of Congo, and 17% in Togo. And when patients were asked about the reasons for not taking their medications, the biggest reason was forgetfulness and high cost of treatment. Those were the top two reasons for not adhering to treatment. And this provides an information on if we're looking to do intervention in these populations, then we will have to target interventions that address these particular reasons why patients do not take their medications. In terms of provider level determinants of hypertension care, I want to go quickly in this study that we conducted in Ghana. And in this study, we measured provider knowledge on hypertension treatment guidelines. And on a score over a maximum score of 23, they scored almost 19 on average, which is quite a higher average in terms of their knowledge. And this is the survey which is also usually used in measuring patients' knowledge on hypertension. So we expected clinicians to do well on this as well. But we're also interested in asking them what are their self-reported familiarity with the hypertension treatment guidelines among those clinicians. Clinicians were, I think, moderately and very familiar with hypertension treatment guidelines. However, I will mention more about those guidelines here later because you can be aware of the guidelines, but be aware of the old guidelines or not the updated guidelines. And we ask them about their self-reported confidence in adhering to hypertension treatment guidelines, but while managing patients. And this survey was mostly answered by nurses and other clinical staff, except doctors who are involved in hypertension management. And since nurses are mostly involved in measuring blood pressure and providing counseling on lifestyles, we see that nurses were more confident in the skill set of things that there is in their scope of practice, and less confident in things which they are not usually involved in, which is like providing a diagnosis for hypertension or prescribing medications. And when you think about the determinants of the provider level determinants of poor blood pressure control among patients, the limited training opportunities is something that comes up among clinicians. When we surveyed the clinicians in Ghana, they mentioned the same, but other studies also mentioned the same. For instance, this one provider said, "I haven't had any refresher training on NCDs. The training in the training schools don't cover these diseases." So usually they get the training in school, but when they get at the clinic, maybe they will get an orientation when they start working in the clinic, but they don't get regular training on the latest evidence. Also, the lack of awareness and knowledge about hypertension treatment guidelines was actually noted in studies in other countries. For instance, 48% of clinicians in Zimbabwe and 43% of clinicians in Rwanda had poor knowledge of hypertension guidelines. And another factor that is on a clinician level is inadequate communication with the patients. And this is particularly important because it comes to the guidance that clinicians receive or the training they receive on how to communicate with the patients. For instance, this one clinician said, "We find it difficult explaining it in our local languages. What is blood pressure in our language? What will you say? Your blood is going up. This is blood that is flowing in the veins." So they find it hard to talk about high blood pressure, which can be understandable because these are concepts which would have to be devised in the protocol, and then at national level, they'll provide guidance on how to communicate and train those nurses and doctors on how to educate patients or even communicate with them. Patient-provider communication is very important in terms of patient adherence to treatment, even the patient being confident that they can manage their condition, reducing complications from hypertension, but even patient satisfaction in just understanding what's happening with them and the care that they are receiving. One other factor that I wanted to mention is the therapeutic inertia. And this is the condition in which a clinician sees that, yes, a patient has a high blood pressure today, but instead of treating them, they just say, "Let's wait and see." And then they send patient back home, only the patient to come back with usually complications from uncontrolled high blood pressure. And we will need intervention to convert this bad inertia to a good inertia, which is where you see high blood pressure, which is not in accordance with hypertension treatment guidelines. Then you work on it until blood pressure gets lower than the threshold that's recommended in hypertension treatment guidelines. And I have to mention that the clinical inertia is not only on the side of clinicians, because the reasons for not treating right at the moment when high blood pressure is noted could also come on the level of cost of care, and even the provider knowledge of those guidelines, knowledge that it's urgent that they act upon it, but also patients' preferences and values, and those can also impact the clinical inertia. I wanted to talk about the health system level, or the determinants of hypertension care. And when I think about health systems level, I often think about the Partners in Health model of health systems, which usually talks about staff. And when we talk about staff, we're talking about well-qualified staff and who are sufficient in number so that they can manage a condition. The staff in terms of availability of equipment, medication, technologies that are needed for managing that health condition. The space, such as the availability in the hospital of space that is sufficient to manage the patients with that particular condition, hypertension in this case, but also the systems such as the leadership, the financing, the information sharing, data usage, quality improvement, all those systems that also are important in order to know how you're performing and how to improve, and also provide vision for better care, and social support for people who cannot afford care. So those are some of the things that we think about when I think about systems or for hypertension care. And I'll be talking a bit about these things in the next slides. And think about the systems, of course, we have to think about the quality gap. There are evidence, and we know in the evidence, we know there is high level of uncontrolled hypertension in sub-Saharan Africa, and we know that there are hypertension treatment guidelines, and they provide guidance on this is the level at which you should start treating. And of course, some countries don't have adapted guidelines to their context, but yes, there are some evidence that's available. And what we're looking for is for those evidence to translate to health outcomes. So reduction in hypertension prevalence, reduction in uncontrolled blood pressure, and here, I don't know why it is going down on quality of life, but increasing quality of life. And in order to bridge that gap, then there is need to find how to implement evidence so that it translates into better outcomes. And when we think about this, then this is the implementation science, which is something that needs to happen, where we need to find, yes, the transdisciplinary research in order to find out how do we implement this evidence in the particular context of sub-Saharan Africa, because we find that evidence, even though it comes out, it needs to be translated to the local context, which, as I mentioned earlier, varies across countries and regions of sub-Saharan Africa as well. The stakeholder engagement, which may need that it's not only the clinicians and the hospital, but engaging other sectors in the country. Which sectors are those that we should be engaged in order to lead about better outcomes, and dissemination and translation of initiatives, and sustainability of approaches. So those are some of the things that need to happen in order to translate evidence into outcomes. And in order for this to happen, one thing that is very important, thinking about the staff, which is one of the things that I mentioned in terms of health systems. I mentioned the clinician level factors, but when we think about the number of clinicians available, that's not an individual clinician factor, but it's a rather system level factor in terms of what's the number of clinicians available. In this study conducted by Newpang and colleagues, it was looking at the availability of physicians and physician density across 172 countries around the world. And it found that in low and middle income countries, there is only, low income countries, there's only 28. In low income countries, there's only 3.5 clinicians per 10,000 people. And in high income countries, there is 30 clinicians per 10,000 patients or people. And this shows the picture in sub-Saharan Africa where you see that there is a very low density of physician to patient, which of course translates to the quality of care that patients receive. For instance, in this study, it shows that Ethiopia was among the 4 global countries with the highest physician deficit. And what does this mean in terms of, for instance, hypertension care? When we think about it, we can think about it in terms of number of visits that patients can make to the clinic every year. And if they go there at the clinic, will the health system be able to accommodate those visits? If we think about one visit a year, then we will see that even some countries still have gaps. For instance, the blue, which represents high-income countries, yes, there is nearly no gap in terms of the ability to provide one visit a year for patients with hypertension. But in low-income countries, there's still around 80% gap in terms of being able to provide even at least one visit a year. And when you look at the ability to provide 3 visits a year, we see that there is that gap in terms of the number of clinicians who are available to provide that gap. And when we think about health workforce, however, it is paradoxical in sub-Saharan Africa, because in sub-Saharan Africa, it faces severe shortage of healthcare workers. However, there is a widespread unemployment in the health sector. And for instance, in this study, which was done by McKinsey and Company in 2024, it shows that approximately 3 million people in 2022 were employed. Healthcare workers, they were employed. However, the supply is 4 million people, which means there is 1 million people who are not employed. And there is the needed clinician in 2022, it was about 10 million people who were needed, 10 million healthcare workers, which shows a gap of about 5.6 million. And it's projected to be there to be a gap of 6 million in 2030. And what this says is that, yes, there's a gap in the availability of healthcare workers, but even those that are available, the governments, they lack capacity to employ them, which leads to people having to leave to go find opportunities in other places, again, further deepening the lack or the gap in terms of the capacity of health workforce in sub-Saharan Africa. Think about health systems, you also mentioned the staff, which is the availability of equipment and other supplies that are needed for hypertension management. And in this study that we conducted in Ghana, we wanted to provide a picture of a hypertension service readiness. Mm-hmm. And we saw that in the 15 health facility, all 15 had at least one blood pressure machine available, which is good. And 12 out of 15 had guidelines available. 11 out of 15 had all the basic lab exams that as recommended in the local guidelines. 11 out of 15 had at least one provider who was trained in cardiovascular disease management. 9 out of 15 had educational materials for hypertension, and 9 out of 14 that responded to this question had all the first-line antihypertensive medications available as recommended by the local guidelines. However, the devil is in the details usually, because when we probed further about blood pressure machines, we found that no facility had a small size cuff, and 1/3 of health facilities did not have a large cuff. And none of the blood pressure devices had a last known date of calibration or inspection, which risks providing inaccurate readings if our blood pressure machines are not routinely inspected. And if people who have small arms or big arms come, of course, there is a risk for inaccurate readings. And the devil in the details, when we looked at the available guidelines, the guidelines that were available were the Ghana Standard Treatment Guideline, which lists all the conditions that are managed in Ghana. But in 2019, Ghana released the guidelines for hypertension and cardiovascular disease management, but none of the health facilities had those guidelines available on site for use, which again means they're still, yes, they have guidelines, but all guidelines, the guidelines that are not sufficient to accurately manage patients with hypertension according to the latest evidence. And one other thing I wanted to mention is that in terms of how are these related to blood pressure outcomes, the system level factors, how are they related to blood pressure outcomes? In this study, I mentioned that we looked at government, private health facilities, and Christian Health Association of Ghana health facilities. And we saw that receiving care at government health facilities was associated with 14 millimeter of mercury lower in systolic blood pressure and 10 millimeter of mercury lower in diastolic blood pressure compared to private health facilities, which means receiving care at private health facilities is associated with poor outcomes in terms of high blood pressure. And why is this case? And I will talk further about that. And as I just mentioned, in terms of patient to physician ratio, higher patient to physician ratio was associated with higher systolic blood pressure and diastolic blood pressure, as of course can be expected. Now, I mentioned that we also wanted to interview the clinicians in order to understand further about these findings. For instance, when we saw that receiving care at private health facilities was associated with poor outcomes, we want to know, why is this the case? And what is happening? Why is this the case? And in these interviews, I want to mention that some of the gaps that we see some of the gaps and the barriers in hypertension management, but there are also some of the opportunities and the facilitators that I will mention. In terms of the gaps, we saw that one of the gaps that are there is in terms of accessibility of hypertension services. And this is accessibility in terms of financial accessibility, where clinicians were mentioning that there is high rate of copayments and the transportation costs and the missed labor and uninsured services, where patients who receive care, there are many services that are needed for hypertension management, but they are not covered by the health insurance. And the copayments were especially higher, according to the clinicians, because it takes long time for the clinics to receive reimbursement by the National Health Insurance Scheme. For instance, some clinicians mentioned that it can take up to 6 months before they be reimbursed for the care they provided to patients. And when they are not reimbursed, they have to keep the care going. So they have to recoup that money through copayments. And that, of course, affects patients, and that is associated with poor outcomes. And in terms of geographic inaccessibility, of course, that was a big problem, where we found that there is no system for decentralized care of hypertension. All patients with hypertension have to go to district and referral levels to receive care for hypertension. And usually that's associated with the long distance of walk and traveling to those health facilities, long waiting, and inconsistency in referral and follow-up of patients. And these findings are, of course, consistent with what is found in other studies as well. For instance, this study by Gedester and colleagues, they mapped the physical accessibility of health services among older adults in sub-Saharan Africa. And this study found that older adults in sub-Saharan Africa, at least 9.6% had to travel 6 hours or more to the nearest hospital. And this was even higher in Sudan, where 41% of people had to travel at least 6 hours to a nearest health facility, nearest hospital. And older adults in sub-Saharan Africa, at least 16% of them had to travel 2 hours or more to the nearest health facility of any type. And this was for 54% in Sudan, which depicts a big lack of access in terms of health services. And this was also seen to be associated with poor outcomes, where we saw that a distance of 30 minutes or less to the health facility was associated with 2 times higher odds of achieving blood pressure control. And this was reported in a study conducted in Ethiopia. And it was reported in a study that we conducted in Ghana, where we saw that, yes, 30 minutes of less travel to the health facility was associated with 2 times higher odds of controlled blood pressure. And even though I mentioned barriers in terms of access, I have to mention there are some facilitators and opportunities. For instance, I have to mention that clinics, they are instituting the hypertension clinics, which are specific for managing patients with hypertension or other non-communicable disease. And what this leads to is that patients, when they get to the clinic, they don't have to wait for a long time to be seen by a clinician. They're rather seen quickly. And we also saw that, for instance, this one clinician said, I think that when it comes to patients coming just to the hypertension clinic, first of all, I think one of the advantages is the less waiting time. And that is something important. Now, what are the recommended strategies for primary healthcare systems for managing hypertension? Of course, some of the things that apply for all people with hypertension or even in the general public, things like universal health coverage, public health intervention for hypertension prevention, effective screening, which could help us get to those people who are not diagnosed, availability of essential medicine and clinical guidelines, and innovation to improve adherence to treatment. But as you remember, I talked more about the insufficient number of clinicians, the task sharing and task shifting among healthcare workers. For instance, one of the things that clinicians said is the nurses' request for higher involvement in hypertension management, which is a resource and an opportunity which is yet to be salvaged. And when you think about recommendation, it can better be depicted by the Hart's pillars of hypertension care, which mention from healthy lifestyle counseling to systems for monitoring, all these factors that, if implemented, they go beyond not only hypertension, but the general cardiovascular disease management. Because it turns out hypertension usually does not occur in isolation. It rather needs to be managed in the context of other cardiovascular diseases that patients have. In terms of policy implications, yes, we need to first think about how do we minimize out-of-pocket spending and financial accessibility of hypertension care. How do we promote team-based care and task shifting and task sharing? Because some of the clinical trials, including TASH trial and ADINCRA study, which was conducted by one of my advisors, they demonstrated that task sharing, which is where non-physician clinicians help in managing, assigning diagnosis and providing prescription for patients with hypertension, it works when nurses are trained or other non-physician clinicians. Decentralizing care so that people do not have to travel long distances and making context-specific guidelines and also involving other sectors such as agriculture, economic empowerment, sport, exercise, those sectors that are in charge of these things can go a long way. In conclusion, hypertension remains a public health challenge in sub-Saharan Africa, and there is a need to scale up context-specific and context-feasible interventions. There's a need to build institutional research capacity to study implementation strategies for and evidence translation to local context. And strengthening health systems would help overcome provider and system-level barriers and even patient-level barriers to hypertension control. Systems in sub-Saharan Africa, I have to mention, they are very resilient because even in the midst of all these gaps, they still provide care. And there are resources. This is a resource that we can build on while we are improving hypertension care. I'm going to stop here, and I'll be happy to take questions and engage in a discussion in the room, but also among people who will be